turned out for what we hope will be a very engaging evening. We've got some great speakers lined up and some excellent community responders as well. We're going to start, though, with some poetry. And our first poet of the evening is Doug Stuber, who is a professor of English at Chonan University in South Korea. Thank you, sir. Peitai Center, January 31st, 2013. Community health centers swell to bursting after private universities buy the general hospitals, start turning away anyone with without insurance. Plenty die who would ordinarily be saved if the Hippocratic oath were as weighty as the almighty dollar. Making big bucks off the already made miserable in society is not reserved for lawyers or mortgage bankers. So let's add hospital corporations, medicinal supplies, overpriced insurance, overpriced schools, nice controls, and the real prospect of Medicaid, Medicare cuts. Sorry, that's price controls. Price controls and the real prospect of Medicaid, Medicare cuts that would make matters worse for who? Guess who? Let's get this straight. First, they build out for-profit jails and FEMA camps. Then they bail out the thieves at the top. Now they figure to balance $1 trillion per year deficits on the backs of the same neighborhood that saw all its jobs disappear and filled the jails. And the way they will start is to finish medical school. That and firing more teachers, allowing more bridges to collapse, and yeah, oh yeah, still hoisting research grants for next generation weaponry. Healthcare, oh healthcare, you glorious symbol of all that is fascist about my dear USA. Lord, keep me healthy. I'm not going to read another poem, but just going to pull out what I received recently from Blue Cross Blue Shield, and that's my poem, second poem for this part of the night. And it's as simple as this. I pay $1,700 a month in health insurance. My pay is $2,400 a month. It's unbelievable, my annual deductible is $5,000 before they cover a dime. But now they sent me this and said my son must clear $5,000 and my wife must clear $5,000 before they cover a dime of any of us. That's not just $15,000. That's $5,000 for the each. And I hope my son doesn't do $5,000 at age 70. I live in South Korea, which also has a big war budget now, but my health insurance there is $28 a month. My going to the doctor, which never needs an appointment, is $7 after insurance. They charge me $2. There must be a way to do it. It's complex, but I go back to about line 18 and I say price controls. And the only way to do that is with single payer. And I don't care if it's government single payer, off government single payer, rehire everyone that was working at Blue Cross Blue Shield, travelers, any of the HMOs that turn themselves into for-profits, put them all to work on single payer. Great idea. Thank you. Doug Stuber, poet advocate. Thank you, Doug. So our first speaker this evening is Gayle Harris, who is the Public Health Director for the Durham County Department of Public Health, right up the street, in a beautiful brand new building. And with more than 40 years of service at the health department, Ms. Harris is involved in a wide variety of initiatives that are geared towards promoting the health of underserved populations here in Durham. She's committed to the challenge of addressing health disparities and disease prevention at the local level. She earned her BSN from Duke University and a Master's in Public Health from the University of North Carolina at Chapel Hill. And I can't imagine anyone who knows health disparities in Durham any better than Gayle Harris. So thank you for being here.
Good evening. Great crowd to see on this State of the County Health Report, and I'm going to give you copies of the report when we finish. Nice little box of paper. I've also inserted some age-adjusted death rates so that you can see the disparities that exist, and they're not included in the report. Just as a refresher, we do, by statute, we have to do a community health assessment every 4 years, and we're going to every 3 years so that we can help our hospital comply with the IRS requirement that they have to do a community health assessment. We might as well do it together, so we're going to do it every 3 years. Our last one was done in 2011, and in 2012 and 13, we have to do a State of the County Health Report that gives you an update on what is happening with the issues that we identified as priorities in the community health assessment. And this time we had this big, huge documents, more than 500 pages long, and we had 97 plus people working on the document. And we went to the community to ask the community, based on the information that we discovered from looking at primary and secondary data, we wanted them to help us set the priorities. And this report gives us progress on the priorities. And the 6 priority areas that we adopted, and we includes the Durham County Department of Health and the Partnership for a Healthy Durham, and then we disseminate and hope that the community rallies around the same priorities, but access to health care, HIV, STIs, obesity and chronic illness, poverty, education, substance abuse, and mental health. This document also celebrates our successes when you look at how we stack up against North Carolina's 2020 goals and the things that are happening in our community, our emerging issues. So we're going to run right through that because we want to get to the heart of the discussion tonight. So I'm going to help frame the discussion, I hope. Most of you know that Durham is a growing population, but we have more females than males, and we are a grounding population. We're becoming a minority, we are a minority majority population. Our Hispanic population has exploded since 2001. When you look at our economic snapshot, we are a community of haves and have-nots, and when you look at how many PhDs and our median income, you don't see the poverty that exists in our community as easily as you may see it in some communities. 7.4% of our workforce is unemployed. We have a growing number of individuals on food stamps. Medicaid, about 42,000 people, 4,000 on health choice. Now, when you look at the 2020 targets, I hope most of you are familiar with North Carolina's plan, the 2020 plan for better health, and you can find this on the Partnership for a Healthy Durham, healthydurham.org, or even on the North Carolina IOM's website that outlines the roadmap that the county has, the state has set forth. Durham has a lot to celebrate. In looking at the 2020 objectives, we had fewer women who smoked during pregnancy, fewer traffic crashes, fewer suicides. We had more children enrolled in Medicaid who received dental care from 1 to 5, and we still have 40% of those kids not getting dental care. We had fewer adults that had permanent teeth removed due to tooth decay. We had fewer unintentional poisoning deaths. We had more adults reporting good, very good, or excellent health, and we had more adults who were of normal weight. They were neither overweight nor obese. We had some other successes and progress. We implemented what is known as the Healthy Mile Trail. We have stenciled this trail it's about a mile in diameter. It goes around a block in the neighborhood where Lincoln Community Health Center is located. It's called Historic Stokesdale, and the neighbors can walk the trail there. And so we're hoping to move that concept out into other communities, empowering the folk in the community to work with us to get those trails implemented. And you get also neighborhood watch, when you have people moving around and get to know your neighbors. We, the state received the Community Transformation Grant, which is, we got the second largest award in this country. I think the state got $7.4 million a year for 5 years. And we're working on a very prescriptive plan that the state has developed so that you can see change across our state. And it's focused on policy change in areas that impact lifestyles, smoke-free environments, access to healthy foods, those kinds of things. And so we are working with our partners in Region 5 of the Local Health Departments Association. Our Board of Health passed a smoking rule that was more comprehensive than any that had been passed previously. So we passed that in February of last year. Our city partners have been a little slow with getting the signs up, and so we're working with them to get the signs up. But we're starting to see, particularly out of county hospitals, you don't see people, smoking as much as you used to. We don't have any designated smoking areas for county employees. The Affordable Care Act, of course, happened, and we've done a lot of education with our community regarding the benefits that many of which are in place now. Now, when you look at our leading causes of death, it's no surprise most of them are related to things that are associated with lifestyle changes. And so cancer, of course, is leading, and I have this cardiology friend who says, but if you put diseases of the heart, the cerebral vascular disease, you could say cardiovascular disease is the top killer. So now this is where we step outside of the State of the County Health Report. I wanted you to see the disparities that exist in our community. This is cancer deaths, non-Hispanic, African-American males, African-American females, and that's the overall rate. White males, white females. Looking at heart disease, African-American males, African-American females, white males, white females overall. Cerebral vascular disease, African-American males, African-American females, white females, white males and all. Diabetes, that's due to type 2 diabetes, African-American males, African-American females. You see a trend? White males, white females. When you look at our infant mortality rate, African-American, non-Hispanic. White, non-Hispanic. Hispanic. Infant mortality rates are said to be the window into the health status of the community. So it is telling us what we're seeing. I threw the AIDS one in because, even though fewer people are dying with AIDS, African-American males, African-American females, and for this particular rate, the rates for whites, you couldn't measure it, and the Hispanic rates were. So now the sources for those, since they weren't in the document that I'm going to distribute, I got them from the State Center for Health Statistics, both sets. Okay. Now, the priorities, access to health care. We are ranked mid-high for uninsured adults, around 22%, that's down from prior years, and high for uninsured children, 10%. Now, the uninsured population, what does that uninsured population look like? They're either underemployed or unemployed, not in the workforce, or they are minorities, especially Hispanics. They have less than a high school education, and they make less than the 400%. We have done some good things in our community and are doing some good things. There's a group called Coordinated Access to Care for Housing for the Homeless. They're particularly looking at respite care and housing for homeless patients. You know, when homeless people go to the hospital, they get discharged. Where do they live? They don't have any place that you can get bandages taken care of and all of the needs met that one would expect after you've been in a hospital. So there's a group that's working on addressing that issue. As I said, we've done affordable care, education, and advocacy. We've also looked at focusing on the issues around transportation in terms of being able to impact access to care. You know, this bus route, is it convenient? Can you get to the hospital? How many transfers do you need to make? How long does it take you to get from certain points, or is it more than 30 minutes? So we're trying to understand that. And when I say we, this is in conjunction with the Partnership for a Healthy Durham. That is the Healthy Carolinians initiative in Durham County that takes the lead on many of these things, and the health department works collaboratively with the partnership. It's an organization of coalitions and agencies, and when you put all the people who work on it, it's more than between 200 and 300 people representing a number of agencies. Our HIV and other STIs, we remain stable at 27.3 per 1,000 of HIV newly diagnosed cases. Syphilis rates have declined over the years. There's a trend line on that. And just as a little information, the target is 0.25 per 100,000 population for where they want us to be. So we still have a ways to go, but we're doing better. We recently received a one-year, the health department received a one-year CDC grant for hepatitis C testing, and we've started that, and we have contract staff that are serving as care bridge coordinators. Once people are identified, we can get them into treatment. So that started in October, and we were just refunded for a 3-year period for our non-traditional testing site, where we go into jails and hard-to-reach communities where we have hard-to-reach customers, and we do HIV testing, syphilis testing, and Hep C testing. Obesity and chronic illness, I said that we had gotten better with our numbers of people along the way, but 59% of our adults and 30% of our high school students are either overweight or obese. 15% of our adults are current smokers. 45% of the middle schools and 26% of the high school students say they eat breakfast every day. And 51% of the middle schools and 20% of high school students get 8 or more hours of sleep. When you look at the disaggregate data, we do a youth risk behavior survey for Durham every 2 years. When you look at the disaggregated data, you know, there's a lot of TV watching and not enough physical activity. So we're looking at the issues and policy changes that could have helped impact that. Both City Open Streets is an initiative that we started, I think, about 3 or 4 years ago under the partnership in collaboration with the city organization. We have a new grant that was written so that we got a grant award from America's Place Streets to increase physical activity and opportunity to open the streets. So we're working with neighborhood improvement services on making those activities available to our community. And we are looking at every opportunity for policy change, working with the school system on their wellness policy and working with the county on its wellness policy and trying to figure out how we can make things better for our community, particularly access to healthy foods, and looking at how we can expand the Healthy Mount Trail activity. Poverty. 19% of Durham's residents live below the poverty line, and 25% of our kids live in poverty. 29% of our single mothers are in poverty, and 53% of our residents spend more than 30% of their income on rental housing. The faith community just had this wonderful summit, Faiths on Ending Poverty. I think we had 500 participants. There's a program, a surplus program, that is is helping people move from poverty. And Durham Health Innovations is another project that the community did in collaboration with Duke. They have a group of people who are working within neighborhoods, and they're doing social prescriptions for people, helping them, saying, you need housing, this is where you can go, these are the things you need. So they're looking at some of the social determinants of health. And I told you about the Kotch program, the medical respite program for people who are homeless. This is a great time to be in Durham because lots of energy is going on around helping people be successful. And so I expect things to just really blow off the top really soon. Education, you heard our superintendent in his presentation, great strides have been made in Durham. Graduation rates continue to rise. The target is 80%, well, 94%. The superintendent has a target of 80% by 2014. And we're at right at 77%. But when you do the disaggregate data, there are people who are not doing as well. And they are people of color. So we need to figure out how to close the gap. Because if we look at Green's pyramid, if you have to deal with those social, economic issues in order to impact population health with the greatest impact. Okay, substance abuse and mental health. From our youth risk behavior survey, we found that 22% of middle school kids and 24% of high school kids report feeling sad or helpless. 9% of middle school and 49.7% of high school students said that they had ever used marijuana. We have the Alliance Behavioral Health Care in our community. That's the old Durham Center that converted to a managed care entity and a waiver delivery system. We have learned, our committee reached out, learned more about bullying and suicide, and they shared that information with our school system partners. And we have a recovery celebration every September to acknowledge people who have made the step toward recovery and been able to sustain it. It's really cool. It's down at the Farmers Market Pavilion, and people have a great time. It's usually like a third Friday in September. Emerging issues. Durham and with the leadership of Duke Health System and collaborating with many community partners, Durham was awarded $6.25 million from the Bristol Myers Squibb Foundation to deal with type 2 diabetes at a community level. And so we are working on improving the quality of life and preventing type 2 diabetes in our community. So stay tuned for that. In fact, we're going to have a TV production starting in February called Living Healthy on Cable 8 that will talk about how people can make lifestyle changes. So it's a very innovative project with the home-based clinical committee team going in to see people using GIS mapping and the data that's in the Duke Health System's data repository. 85% of us go to Duke for something, and they have lots of data. But we're doing using a risk algorithm to look at people who have diabetes and look at their potential for having poor outcomes and trying to deal with that, and using the data to geospatially map where those individuals are and so we can target our interventions. Social determinants of health. At the last health summit last year, we talked about social determinants of health. In October of this year, we reconvened the group. Dr. Jenkins, head of Duke University Health System, and I reconvened a smaller group to look at those issues. And we have teams working on poverty, education, and the homeless issue. And on March 22nd, from 8 until 3 at the Marriott, we'll have another health summit. So you need to register. It's free of charge, and so you can come and see what's happening at the participate in the discussions. But a lot is going on to see if we can address those issues that tremendously impact health. The World Health Organization said you can no longer blame people for having poor health, nor can you independently attribute a person's behavior for having good health. It is the context in which they live that we have to take into consideration. And many of those things are beyond the control of individuals that are suffering. So that is Durham in a snapshot. And so we can just pass out these State of the County Health reports so that you have that. And I'm available for questions if you have. Yes.
What you said that you health risk
Youth risk
survey every 2 years. When was the last one done?
11, and we're talking with the school system now. We have the surveys ready to go, and we're talking with them now to see what the next step is.
And then did you know that there was not a recovery celebration this past year due to just lack of momentum?
I was away, and so no, I did not. Yeah, but we will have another one. That is on the agenda. Is that correct, Sal? Yeah.
Yes.
Yeah. The plan is to have it contained. Yes.
This surveys individual complete them, and what response rate do you have?
We have worked with the schools. The last one we did, it coincided in the grade testing, so that wasn't a good time to do it because there was some change in the personnel that is helping with that. This year we're trying to do it before end of grade, and we do, the schools identify a grade for us to use. We try to follow the state's format, and so we allow the parents to opt out of having the kids participate, and if they don't send them, no, don't take this test, they're included. The survey, yes.
I mean, how accurate do you think that the behavioral surveys are? Because as a high school student or a middle school student, you have to take behavioral surveys as well. And I know me and some of my classmates didn't really take it as serious as it might should have been, because at that moment in time, that's not what we're thinking about, so we don't really understand or know what kind of data the county at the time was trying to collect. So is it accurate each student completes it truthfully, or?
It is self-reported data, we do have to understand that, and it is the survey that is developed and used by the CDC. And so they've been doing this for years, and so while you may have some folks that go to the other side and, try to, I was talking to my 34-year-old, and he started telling me, I was in 3rd grade and I tasted Danny's. I went, what? He just told me that over Thanksgiving. And so, kids talk about drinking and having their first drink at their parents' home and everything, and I'm going, good Lord. So I would say it's probably pretty accurate.
I have 3 questions.
Oh, wow.
One, since there's no smoking allowed in the county buildings, where are all those smokers smoking now?
We use, some of them go stand by the railroad track. Yeah, and they go to other properties. Some people still try to smoke on our properties, and we don't have the staff to police or instruct folk about not smoking. So like this morning, I looked out my window. No, it's just there were 2, 3 people smoking. I grabbed up some no smoking cards, went down and introduced myself to them, and they were standing right behind my pretty sign smoking. and people are very gracious. They don't get belligerent. I've never had anybody to tell me, to be ugly. My friends don't walk with me when I do this. Oh God. But I just walk up to people and say, hi, and have a good conversation, and say, well, I'm the public health director. Do you realize there's no smoking here? And so I'd appreciate it if you did. And they go, oh, and so they kind of move away. And so we're counting on the fact that we do this enough that the community will say, look, that's a no smoking sign. You really shouldn't smoke here. And so we're hoping we'll get there.
Okay. Second question, can you tell me what differentiates overweight and obese?
There is a formula called body mass index, and I can't begin to tell you it's height in inches times weight and squared and all this kind of stuff. But there is a calculation. But what that calculation does is it gives you a number, and numbers that go from 24.9 to 29.9 is classified as overweight. No, 25 to 29.9 is classified as overweight. Anything over 29.9 or 30 is obese. Now, for a person who is 5'8", they should weigh 164 pounds. My nephew says, I'm not overweight, I'm just packed strong.
My last question is, in your substance abuse percentages, there was no mention of alcohol use.
There is alcohol use, but my staff member who put it together, she didn't summarize that. But our youth risk behavior data, I don't know if it's posted to the healthydurham.org website, but at least the prior year, 2009 is up there. I don't know if 2011 has been posted, but you can find the data.
Thank you.
Yes.
I was struck by your statistics about the numbers of middle and high school students who were sad or feeling helpless. 22% in the middle school, I believe, and 24 or 25% in the high schools. And I just wondered and that it wasn't disaggregated, but I'm sure it corresponds to some of the other survey questions. So I just wondered what work is being done in the schools around.
One of the superintendent's goals, one of the goals in his strategic plan is under mental health and safety. And the Durham Center, the Alliance for Behavioral Health Care, has worked with the schools to place mental health professionals in some of the higher risk schools. In other schools, we also have a team, child and family support teams, where there's a nurse and a social worker who can work with kids who are at risk of academic failure or out-of-home placement. And there is a crisis response team. The counselors in the schools are being trained on identifying kids who are depressed as opposed to kids who are just not interested in participating just cause. And so it's a work in progress. A lot of strides have been made. In prior surveys, it was our Hispanic population, the kids were feeling more depressed. And I can't remember how the disaggregated data breaks out in 2011 survey, but the system is paying a lot of attention to mental health issues because of the need for kids to be healthy and able to be ready to succeed.
And I'm going to exercise the power of the moderator. We probably pepper you with questions the rest of the evening, but thank you, Gayle.
Thank you so much. Would it be disruptive if I pass these now, or should we just put them on the table for people to get on the way?
Let me do that.
Okay, that would be great.
So I think that was a great snapshot of Durham, both the challenges that we face and some of the programs and initiatives that we are trying to address those challenges. Our next speaker is Jonathan Kotch, and Jonathan is a board-certified pediatrician and specialist in preventive medicine. He's the Carol Remmer Engel Distinguished Professor of Children's Environmental Health in the Department of Maternal and Child Health at the UNC Gillings School of Global Public Health. He has degrees from Columbia, Stanford, Cambridge, and UNC Chapel Hill. His research has focused on child health policy, child maltreatment, child injury prevention, and health and safety of children in out-of-home child care. He's published widely in over 80 peer-reviewed, he has over 80 peer-reviewed articles, and he's authored the 3rd edition of a textbook on maternal and child health. He currently serves as the president of Healthcare for All North Carolina, and the NC state chapter of Physicians for a National Health Program, and is a member of Occupy Health and Wellness North Carolina. All of those organizations pushing hard for a single payer system, I believe. And he lives right here in Durham. He's married. He has 3 grown sons, 5 grandchildren, and he was my professor.
When you get to a certain age, people just pop up out of the audience and say, "You were my professor." I remember you. It's really great to see everybody here tonight. Thanks for coming. My remarks are deliberately brief because we want to have as much discussion as possible. And thanks very much to Gayle Harris for giving us the context for talking about health disparities, specifically in Durham. But Durham isn't unique, as you all know, and that those disparities will be found anywhere else in the United States. And I would address one answer to the question about SAD and helpless. I don't know the data for SAD or helpless by race or ethnicity, but I do know that suicide deaths are far less in the African American community. So there's one disparity that goes against the trend in a very positive and hopeful way. So I just want to make that point. So good evening. You know who I am. Tonight we're talking about health disparities and how healthcare reform under the guise of the Affordable Care Act offers promise for reducing health disparities between ethnic and racial groups in the United States. The first, being a professor, I have to define my terms. So, according to the CDC, health disparities are differences in health outcomes between groups that reflect social inequalities. So why don't we call such differences health inequalities? I think the answer is political. Someone thought that disparities was a less inflammatory word than inequalities. But the fact of the matter is that for racial and ethnic minorities, differences in health status are inequalities as surely as differences in education and housing and jobs are inequalities. They're the result of social and economic discrimination. So from now on, I will refer to health inequalities between racial and ethnic groups rather than health disparities. So let's take a tour of some of the more egregious health inequalities. As you heard, I'm a pediatrician. I teach maternal and child health. So for me, the most glaring inequality, as Gayle said, the window on everything else about health inequalities, has to do with birth outcomes. Infants born to African American women are much more likely to be born too soon, too small, and therefore they're 1.5 to 3 times more likely to die in the first year of life than infants born to women of other races and ethnicities. This is a huge injustice. You might have noticed in Gayle's slides about birth outcomes, infant mortality, that the Hispanic infant mortality rate was the same as the white rate. The African American rate stood out. But there is a phenomenon that's referred to as the Latino paradox. The Latino paradox is that birth outcomes for second and third generation Latino women are worse than for their mothers. Those immigrant Latino women look statistically like domestic white women in terms of their birth outcomes. The more Americanized those Latinos become, the more they begin to look like African Americans. They're not discriminated against in Mexico. discriminated against in the United States. There are many other inequalities that affect children and adolescents. Racial ethnic minority groups who are more likely to live in urban areas continue to experience a disproportionately larger impact of air pollution, resulting in more asthma and more respiratory conditions. Disparities persist in adolescent birth rates for Hispanics and non-Hispanic blacks that are 3 and 2.5 times those of whites, respectively. I consider this health inequality, not because I'm against anyone who so chooses having babies. Unfortunately, many adolescents who become pregnant do not choose to do so because most adolescent births are unplanned or mistimed, and because minority adolescents are less likely to have access to birth control. We know that homicides disproportionately affect young African American males. On the other hand, African American males are less likely to commit suicide than their non-Hispanic white counterparts. Unfortunately, suicide is especially a problem for Native American and Alaska Native adolescents and youth. Turning to conditions that affect adults, conditions with which I'm not very expert, coronary heart disease and stroke, as we've seen from Gayle's slides, are more likely to affect African Americans. Both African American and Latinos are more likely to be obese than whites. Not surprisingly, they're also more likely to have diabetes. And the list goes on. Hypertension, HIV/AIDS, some forms of cancer are other examples of health inequalities that differentiate the privileged from the less privileged in our society. There are also differences in access to health care among racial and ethnic subgroups. Latinos and non-Hispanic blacks are significantly less likely to have health insurance than non-Hispanic whites. And as a result, minorities are much less likely to take advantage of preventive health services, such as immunizations and cancer screening. And they are more likely to require unnecessary hospitalization. So to the extent that the Affordable Care Act increases access to health insurance and to health care, there is a hope that health care reform can reduce inequalities in the United States. In fact, Jean Nickel, who's the director of the Center on Poverty, Work, and Opportunity at the UNC School of Law, has said that the Affordable Care Act is the greatest civil rights legislation in 50 years. And he told me that I might share that quote with you. Here are some of the ways that the Affordable Care Act addresses what they call health disparities, starting with, first, affordable insurance coverage. A new health insurance marketplace will be created in 2014. This will offer one-stop shopping so individuals can compare prices and benefits and health plan performance on easy-to-use websites. The marketplace will guarantee that all people have a choice for quality, affordable health insurance, even if job loss, job switch, move, or illness occurs. The new law also provides tax credits to help more Americans pay for insurance. Number two, preventive care. Medicare and some private insurance plans will cover recommended preventive health services such as regular checkups, cancer screenings, and immunizations at no additional cost to eligible people. Number three, coordinated care. The law calls for new investments in community health teams to manage chronic disease. These teams are in fact modeled on North Carolina's community care services for Medicaid. This is important because minority communities experience higher rates of illness and death from chronic diseases like diabetes and kidney disease, heart disease, and cancer. Number four, diversity and cultural competency. The Affordable Care Act expands initiatives to increase racial and ethnic diversity in the healthcare professions. It strengthens cultural competency training for all healthcare providers. Health plans will be required to use language services and community outreach in underserved communities. Improving communications between providers and patients will help address health disparities, particularly in Hispanic communities which currently have high numbers of uninsured people. Don't forget, however, that undocumented residents are specifically excluded from the benefits of the Affordable Care Act. Number 5, health providers for underserved communities. The Affordable Care Act increases funding for community health centers, such as Lincoln, which provides community health care for everyone, no matter how much they're able to pay. Health centers serve an estimated 1 in 3 low-income people and 1 in 4 low-income minority residents in the United States. 6, ending insurance discrimination. Insurance discrimination will be banned, so people who have been sick cannot be excluded from coverage or charged higher premiums. Women will no longer have to pay higher premiums because of their gender. New funding will be available to collect information on how women and racial and ethnic minorities experience the healthcare system, leading to improvements that will benefit these groups. These improvements are all good things, but their actual impact on health inequalities remains to be seen. The underlying causes of health inequalities, poverty, discrimination, unequal educational opportunity, unemployment and underemployment, low quality housing, exposure to environmental pollution, won't be touched by the Affordable Care Act. Our work in reversing those inequalities goes on. Thank you, and I look forward to hearing what you all have to say. Do I get the call on a questioner?
You aren't shy about this topic, but you didn't even mention Medicaid expansion.
Well, I mean, that's a whole other evening's conversation.
But you would point out that it's the most significant way of improving the health of the poor and correcting racial disparities that are linked to low income.
Except for the fact it's not likely to happen.
Well, but that's still being debated, and we all have a chance to make our opinions heard.
You're absolutely right. So the fact that Medicaid expansion would make it possible for many more poor people to have access to medical care should disproportionately improve the health of those poor people, reducing the disparity. And therein lies the battle. Sir.
I just heard in the news tonight that the Republican powers that be have made it clear and put it in writing that they're against the Medicaid expansion, and they're in favor of a federal-only health benefits exchange. The state had pursued a cooperative agreement between the state and the federal government, just in case some of you didn't know, but it's some bad news tonight.
Well, that is my understanding as well. I think what happened today was that a Senate committee, probably the Senate Insurance Committee, passed this legislation, which means it next goes to the floor of the Senate, and it still has to be debated in the House. The identical bill has been introduced in the House.
Well, the original bill was approved in the House, and not approved in the Senate.
That's not my understanding. There was a bill in the previous legislature in 2011 that would have set up a health insurance exchange that would have been controlled by insurance companies, which passed the House and did not pass the Senate.
That's just what I said. Yes. I thought you said it the other way around.
Well, no, that legislation dies because we have a new legislature now. So that doesn't matter. What matters is what you just said, the fact that the Senate committee passed this bill, which would prevent North Carolina from expanding Medicaid and prevent North Carolina from participating in the health insurance exchange.
Exchanges.
Exchanges?
Prevent them from participating in the health insurance exchanges. Yeah. Did you leave exchanges off? I didn't know if you.
No, I may have, but prevents the government from participating. But North Carolinians will be able to, as individuals, participate in a federal exchange.
Yeah.
Thank you.
Jonathan, thank you for putting that and listing the benefits in a way that I could understand. Are those available the way you put it anywhere online?
Well, actually, they are. That list of 6 things is from healthcare.gov.
Okay, thanks.
The language under there has been edited a little bit by me, but those 6 points are there. Go ahead, Gus. and then
Well,
we
that's
should probably
okay,
go
go
on.
ahead.
Well, you save your thought, and we have some excellent responders to hear from.
So at this point, we want to open it up for general discussion, but before we do that, we want to hear from a couple of community respondents that have agreed to comment on both Gayle Harris's talk and Jonathan's. As you see on the program, I was originally supposed to be a community respondent, got pressed into service to be the moderator, and then when I walked in tonight, lo and behold, Bill Jenkins came right behind me. And so I turned around and asked Bill if he would be a community respondent in my place so I could just focus on being the moderator. And for those of you who don't know Bill, he told me to make sure I mentioned that he was born on a sea island off the coast of South Carolina. He is Geechee. Yes. All right. And Bill has 40 years of experience as an epidemiologist at the Centers for Disease Control in Atlanta. He also taught at both Morehouse College and Morehouse School of Medicine at epidemiology and biostatistics. While at the CDC, he managed the Tuskegee Benefits Program, as well as the ethics center that emerged as a result of the Tuskegee experiment debacle. And he currently lives here in Chapel Hill. We're trying to woo him to Durham, but it's a tough sell, I guess. And he is currently consulting on the expansion of community health centers, which are supposed to grow vastly in number as a result of the Affordable Care Act. And our other community respondent is Mary White, seated right here. And Mary is a retired educator. She's taught in Virginia, in Washington, D.C., and here in North Carolina. She founded youth organizations in D.C. and here in Newburgh, I believe. She is a very long time community activist, beginning in her college days at Johnson C. Smith University in Charlotte, which was the second university to participate in civil rights sit-ins in North Carolina. And she is a proud member of Occupy Health and Wellness North Carolina. So, Mary, can I ask you if you would lead off?
Good evening. I'm Mary White, as has been said, and I'm here to speak on behalf of Occupy Health and Wellness in a way of responding to information that has been given tonight. First, I want to sincerely thank the organization, the organizers, who produced this event, as well as the panelists for sharing their thoughts. So I ask you to join me in giving them a hand. Occupy Health and Wellness is one of the organizations with which one of our guest speakers, Dr. Kotch, works. It was formed out of Occupy Durham and Occupy Chapel Hill and Convo movements in January 2012. We envision healthy, thriving communities where all individuals and families have equal opportunity to enjoy optimal health and wellness, and they choose to exercise their right to health care that is high quality, affordable, and accessible. Our mission is threefold. First, educating and empowering people about health policy. Second, implementing an efficient, universal, publicly funded, not-for-profit healthcare system. Okay, I'm gonna say that again. Publicly funded, not-for-profit healthcare system. And third, eliminating the political influence of for-profit health industry lobbying. We've been working on educating people about the Affordable Care Act, or ACA, the need for healthcare reform and about the need for healthcare reform in general, and on the relevance of complementary and alternative health. We will focus our response today on something that was taken off the table early on in the health reform debate, and that is single payer or universal health care. This is different from universal health insurance, which is something the ACA moves toward. But for many people, health insurance will still not be affordable. There will still be co-pays and co-insurances. There will still be health insurance premiums that people will have to pay, even though there will be subsidies for people making up to 4 times the federal poverty level. In addition, with the Supreme Court striking down the state mandate to expand Medicaid to include all people making less than 138% of the federal poverty level, we'll have a portion of people making very little money who are also not eligible for the subsidy. Currently, Medicaid only covers all children, pregnant women, and some portion of parents and some portion of people with disabilities. Conversely, a Medicaid expansion will cover all adults, even those without children, up to 138% of the federal poverty level, as well as all parents and people with disabilities who make up to 138% of the federal poverty level. Single payer would also provide a national system of health care and would help take often for-profit insurance companies out of the mix. We believe that profiting from illness is unethical, and I'd like to say that again. We believe that profiting from illness is unethical, and if there's anybody out there who agrees with me, I'd like for you to repeat that after me. Profiting from illness is unethical. Profiting from illness is unethical. It's good to hear that, because that's something that people don't hear very often. And so we need to put that into our mental processes and think about that and work toward it. Yet that's exactly what the health insurance companies do. And although the ACA does a great job of expanding who can be eligible for health insurance, including requiring insurers to cover people with pre-existing conditions and allowing children to remain on the parent's insurance until age 26, it still does not do enough to rein in the unethical profiting from illness. And I do have an example of that I had a godchild recently who is actually indigent, and I thought I was going to help her because she had a heart condition and she needed her medication. And so I went with her to the pharmacist and tried to get a prescription filled, and decided I'd go ahead and try to pay for it until the clerk said it was $500. And I could not believe it, but instead of getting angry with the clerk, I had to get angry with a system that allows such an egregious type of charge to be paid for common people who just need their medical attention taken care of. And I discussed that with my brother, who's from Washington, D.C., over here, who's visiting me today, happens to be visiting me today. And he says, that's nothing. When I had my health problems, my pharmaceutical bill was about $800. But because he was the chief of staff of the Washington Teachers Union, he didn't have to worry about it. But that means that insurance companies, as well as the government, are the ones who are actually making these horrendous payments, and thereby we have our fiscal cliffs and other problems that this country is coming to. So that's a lot that we need to be thinking about. So now, here's a way that ties back to health disparities. Disproportionately, many people of color live in poverty. So the Medicaid expansion is essential for ensuring that more people are covered by that program. On the other hand, undocumented people will not be able to benefit from this insurance, and they will have no health care service. So probably about 11 million people will still not be covered. And then we need to keep in mind that just providing health insurance will not eliminate health disparities on its own. We still need people to come into care and visit their health providers. And then there's another aspect of this that doesn't even depend on health care or health insurance. Looking at where people live. Do people have access to high quality, affordable fruits and vegetables? Do people have access to safe places to exercise or at least walk around? There are many areas of our country, including right here in Durham, that are food deserts. That means they don't have a grocery store within a walking distance. Access to affordable, healthy food and places to exercise are another piece of the puzzle that we have to keep in mind if we're going to work toward eliminating health disparities. It's important for us to approach improving health from different directions, including looking at how policies and reform can improve things, as well as community level changes like making sure people have grocery stores nearby, and individual level changes like making sure everyone is educated about the foods they eat and how they can have an active role in improving their own health. So this is where Occupy Health and Wellness North Carolina stands. We are committed to work toward these goals, but to be fully successful, we need a great deal of help, organizing, and intent to recommend legislative changes on this issue. We appeal to anyone here tonight who agrees with our aims to join us in this effort. If you're interested in learning more about our group, we have flyers available on the back table. You can talk to me or one of the other group members. I'm going to ask a few to stand. Kotch, she's a technical support person and actually the supplier of the presentation information. Anya Bach is not here, I don't think, but she's also an excellently vigilant in keeping us on our toes. And Berganus, if he could stand. He's a businessman, our meeting reporter, and the glue that holds us all together. Kevin Smith, I think, is not here, but he's another hardworking and avid member. And of course, Dr. Jonathan Kotch, our quintessential medical professional. So I would like to have all other Occupy Health. These are the people who've been there for the longest time that I've known. But we have some new blood that's helping us to revive what our plans are. So all other Occupy Health and Wellness members who are central to our group and development, would you please stand? Okay. So take a look at these people who can inform you more about us. Please feel free to come up to them and ask them about our organization. You will note that many of these people are related to their professional or related to the healthcare area. But then there's always room for people like me who like to say that you might need to hear the voice of a common person sometime. So I'm saying that we need everybody in this process. If our work is to be successful, we need many, many more participants. So please consider becoming a part of us. Come and share your ideas and concepts to help us reach our goals. We'd love to have you join us. Thank you for your time.
I guess I'm an expert because I know nothing about Durham. I am a bar statistician epidemiologist for 40 years, I guess. And one of the things I think I started with is the language thing. when we first coined that phrase, health disparities, in 1990, we were moving away from the issue, calling it minority health, and the reason was to focus on getting people focusing on the issues and creating action. And the reason we use health disparities is simply because we were quantitative types. That's what we do. That's how we thought. And as the movement grew, it moved from health disparities to health inequalities, and now to health equity. Health inequalities being those disparities with clear understanding of their social determinant and support, and then health inequalities are focusing, health equity is focusing more on the philosophical concepts of justice and fairness. And so it is moving in that direction. I think it's absolutely fun, it's absolutely wonderful, but we weren't inspired when we came up with health disparity. It is how ideas grow and how words are used. For example, I don't use the word race to describe human beings, Homo sapiens. I think the American Anthropological Society said 103 years ago that no such things exist. And yet most people, even African Americans, are programmed to use this word to describe people. It's absolutely amazing to me. But you can program people to force them into conceptual boxes that therefore doesn't allow them to think outside of the box. If you didn't use that term, you would then focus on the factors that actually cause health disparity. You would focus on racism rather than race, and that leads you in a different direction. You would focus on culture in communities, which most of us have no idea about culture and community. One of the most interesting examples of that is this word, the Tuskegee experiment. Now, the Tuskegee experiment was actually the economic development program that Booker T. Washington and others started in 1895. But a young editor that worked for Jim James in writing his book on the Tuskegee study of untreated syphilis in the Negro male wanted to use a shorter, graver term. He used it because he had no idea about African American history. But today, if most people in our community, in the African American community, are now programmed to use a word that a young guy used because he had no idea what he was talking about. It is absolutely amazing to me. The problem about being my age now and thinking back on my experience over the last 40 years is that it's scary. There are a lot of great things. We're moving forward in a lot of ways, but also we do not have a lot of people stepping back and rethinking the issue. Last week, and someone who I've been arguing with for 30 years, maybe more, David Thatcher was the Surgeon General. David was over at Duke the other day. And when we first started this argument about what proportion of health disparities are determined by health care, I think David was saying it's 70%. After arguing data, working with Mike, the English guy, whatever, Mohammed, whatever, it's now down to 17% of health disparities is due to health care. You know, the idea, there are many ideas that we need to rethink. For example, I am obese. Do you really think I don't understand that? Do you really think if you educate me, I will not go out and get a McRib tomorrow? Unlikely. You know, the issues that determine our behaviors are far more complicated than just education. It's not knowledge. We have, when we started working on HIV in 1991, at that time I was head of the research center for the SPD division. So we were looking, I was there when we caught those first 6 cases looking at what we called GRID back then. Within the first 2 years of the program that I managed, which provided funds to minority HIV organizations around the country, within those first 2 years, we had gotten the knowledge rate up to 98% on what causes HIV. Did that stop people from having unprotected sex? I'm here to tell you, it did not. You know?
very simple thing that is so obvious when people step back and rethink about the problem. So, as a community people, I think, as a community person now, I think it is important to sort of rethink what the issues are. For example, I can't remember his right now, but one of the most famous epidemiologists in the country who got millions of dollars studying coronary heart disease, said we should rethink the whole idea of disease-focused research. The same ideologic factors that cause Syme, Leonard Syme, great guy, wonderful thinker. Spending a couple of hours talking to Leonard Syme over coffee is a great thing for any young person to do. But you look at the ideologic factors that cause coronary heart disease, cardiovascular disease, diabetes, they're all the same. It's the ideologic factors to think about. And what are those ideologic factors? Those ideologic factors including things like simply having control over one's life. You know, how do you provide education in schools so that young people believe that they have some control over their lives? This is not complicated, you know, but if we don't have people thinking about it, it just won't get done. I mean, I think we just have to rethink some of these factors. So I won't hold you up with my conversation, because as you know, I'm an expert with absolutely no information whatsoever. But, you know, I'll be glad to answer questions with Ms. White and the other panel members as best I can.
Thanks, Phil. Expert on nothing but full of really compelling ideas. And I'm reminded of, I teach a course in public health policy, and one of the readings that I have students do is by a woman named Connie Themba Nixon, who wrote a book called Making Policy, Making Change, in which she debunks the myth that knowledge is power. And she talks about power as having the resources to act on knowledge, which is often lacking. I'd like to just open it up now for general discussion, questions, comments on any of the presentations, reactions.